Welcome to the Introduction to Performance Validity Assessment. So, neuropsychological assessment assumes that patients are engaged, motivated, and cooperative throughout the evaluation. Without this engagement, cognitive and emotional functioning will not be accurately captured, and an inaccurate description of the patient's cognitive, emotional functioning could result in myriad iatrogenic effects. So, for instance, the practitioner could come up with an incorrect diagnosis or incorrect severity of symptoms. They may make recommendations for unnecessary or costly medical workup, such as an unnecessary MRI, which is both expensive and can have negative effects, such as radiation exposure. They may come up with recommendations for unnecessary or harmful treatment, such as medications that may have harmful side effects. It may result in recommendations of restrictions in independence, and also it could reinforce non-credible symptoms. So neuropsychological assessment generally includes two different methods of validity assessment. The first is assessment of symptom validity, or the validity of self-reported symptoms. So for instance, when a patient is completing a questionnaire that's asking about their symptoms and severity of symptoms, the neuropsychologist would want to make sure that there are some metrics of symptom validity or symptom validity tests that are being administered to ensure that their symptoms are being validly reported. There's also performance validity assessment, and this is assessment of the validity of the observed cognitive performance. So when we administer measures of attention, processing speed, learning and memory, and executive functioning, these performance validity tests help us to know whether or not the cognitive data that we collect is valid. And why do we need to assess performance validity? Well, patients often have incentives to underperform on neuropsychological testing. These could be external incentives, like financial incentives, such as if the patient is involved in a lawsuit or if they have a disability claim. External incentives could also include accommodations, like if the patient wants extra time on testing or they need a special accommodation in the workplace. And external incentives also include medications. So, for instance, in ADHD evaluations, the patients may be looking for medications to assist with that. And these external incentives could be reasons why patients want to appear more impaired than they actually are. There's a lot of literature showing that external incentives strongly increase the level of performance validity, or the likelihood of performance validity test failure. There are also internal incentives, such as the patient assuming the sick role or gaining increased attention, sympathy, and care from others. Other internal incentives include relieving guilt, anxiety, or internal conflicts. And there's a fair amount of literature looking at whether clinicians are able to distinguish between individuals with valid and invalid presentations without performance validity tests or symptom validity tests. And what the preponderance of the research shows is that clinicians are not so great at doing this without formal measures of validity. So whether they're basing their conclusions off of an interview or off of a review of test data, their conclusions are much better if performance validity tests and symptom validity tests are used. So objective validity testing is imperative in almost all neuropsychological evaluations. And the state of the science really is that if you're not going to include validity testing in your neuropsychological evaluation, you really need to provide written justification for why you did not do so. So continuing on the theme of why do we need to assess performance validity, we know that there's a very high rate of performance validity test failure in certain samples, especially in samples with external incentives or financial incentives to perform poorly. Armistead-Healy found that 58% of veterans with a history of mild TBI failed performance validity tests. In other words, they did not have data that could be interpreted. And these rates are similar to what we see in the civilian sector in mild TBI samples. So we do know that in certain samples, there are very high rates of performance validity test failure. And we also know that performance validity test failure is related to worse neuropsychological performance and can make a mild TBI patient look more severely impaired than a severe TBI patient. So we're going to zoom in on this chart. And here we see on the x-axis a bunch of different conditions, and on the y-axis the effect size of each of those conditions on cognitive testing. So if you look at the third bar, the first one that's highlighted, or the third one from the left, you see that mild TBI 1 to 3 months post-injury has an effect size of about 0.1 on neuropsychological testing. If you go over 2 bars, that's showing the effect size of moderate to severe TBI more than 24 months after injury on testing, and that has an effect size of about 0.8. So significantly higher than the effect size of a mild TBI 1 to 3 months post-injury. But if we go all the way over to the right, there we see the effect size of exaggeration or invalid performance on neuropsychological testing. And that's an effect size of about 1.1, which is even larger than the effect size of moderate to severe TBI. So if you have a healthy individual with no TBI, but they are exaggerating or responding invalidly, they are going to appear more impaired than a patient with mild TBI or a patient with a moderate to severe TBI. So what this tells us is that responding invalidly really does impact the neuropsychological test results. So it's imperative that we take this into consideration before just interpreting the results without these measures. So in order to assess performance validity, we can use 2 different types of measures. There are standalone measures that have been specifically developed to detect invalidity, and there are also embedded measures developed conducting research using existing cognitive measures to find particular metrics that are sensitive to invalid performance. And these embedded measures can be very helpful because they can save time. So they generally don't add length or much length onto the neuropsychological evaluation. And they also allow for assessment easily. It's relatively easy to score them, and if they can be incorporated across many different cognitive domains, that allows us to assess validity across several cognitive domains as well. So when you're going to be administering PVTs, which should be for almost every, if not every, evaluation that you complete, you should be informing the patient of the importance of putting forth their best effort in order to aid your interpretation of the results and your recommendations for treatment. This can happen during the interview and also at the beginning of the testing session. Just a reminder that they should try their best. You don't really want, there's some debate in the literature of whether or not you should tell patients that you will explicitly be testing their validity. But it is generally thought to be good to encourage them to put forth their best effort. You should be using multiple different validity measures throughout the evaluation because engagement and motivation can fluctuate across the exam. And validity assessment should include an assortment of PVTs that appear to assess a variety of cognitive domains. So there are PVTs that appear to assess learning and memory, PVTs that appear to assess attention and processing speed, and you should not be limiting yourself to a single domain, but should be getting as broad a sampling as possible. Similarly, you should be using both standalone and embedded PVTs. And when you do select particular PVTs, it's important to prioritize relevant research conducted with samples similar to that of the patient. And ideally, you really want to keep specificity at or above 90%. So this is something that test developers take into account when developing standalone or embedded PVTs. They really want to make sure that the specificity is at or above 90% so that we reduce the chance that we are incorrectly concluding that someone is putting forth an invalid performance. This oftentimes mathematically must come at a cost to sensitivity, but it's thought that the cost of incorrectly identifying someone as putting forth poor effort outweighs the cost of incorrectly stating that someone was putting forth adequate effort or responding validly. So we do like to maintain a very high specificity, and that does come at the cost of sensitivity, but that can be minimized through the use of multiple PVTs.